I have no big data to analyze or to discuss with you, and I will also not talk about automatization and how you can limit the workload. I could discuss with you how good my reagents are, and they are very good and stable and so on, but there's a completely different story and a completely different journey I would like to take you with me. And this is understanding the disease to guide our diagnosis and to really, with the knowledge about the disease, understanding and changing the approach how we diagnose patients. And I would like to take the example of ADAMTS-13 in the diagnosing of thrombotic thrombocytopenic purpura. So TTP is very small printed, but mainly there's been developments for the last 100 years, and in 1924 there was actually the first description of hyaline thrombi in organs in a subgroup of patients, which actually then Mr. Schulman figured out that plasma factor was causing this disease. And it took quite a long time until the 1990s that several labs identified ADAMTS-13 as an enzyme which cleaves the von Willebrand factor and its inhibitors to be the cause of this disease. Below our error, there is the treatment options which have been evolving over the last decades, from plasma infusion to plasma exchange, with now newer drugs available which really target the disease based on the knowledge we gained over the time. So just to give some definitions which you might hear from the clinicians, like the TMA, which is a big population of patients, the thrombotic microangiopathy, which is really caused by thrombus in the capillary laterals. And this is a big group of patients which different causes to this thrombotic, and very much in contrast to the TTP patients, which is the thrombotic thrombocytopenic purpura, which is basically characterized by a microangiopathic hemolytic anemia, where this platelet-rich thrombi develop. And this is not due at DIC. In the time where TTP was better characterized, we found out that TTP actually comes in two flavors. One of them is the acquired or autoimmune TTP, which is caused by autoantibodies, or I previously named Mr. Schulman the hereditary TTP or Upshaw-Schulman syndrome. So this is the first description by Moschkowitz of these hyaline thrombi, basically platelet-rich thrombi in these patients. Due to the microvascular injury and the thrombi in them, the fragmented red blood cells or schistocytes develop, which we then see in the laboratory. And for those of you who are more knowledgeable about the von Willebrand factor, there are unusually large von Willebrand factor on the right panel, where there is the TTP patient compared to the normal sample on the left. So why is this a problem? And there has been described in the literature the classical pentate of TTP, which is the microangiopathic hemolytic anemia, thrombocytopenia. This is what we have with quite a lot of patients. But the classical pentate include neurological disturbances, renal failure, fever. But actually only 7 to 40% of TTP patients exhibit this classical pentate. And there is a huge rate of mortality if these patients are not characterized or identified and adequate treatment is initiated. So therefore, other diagnostic criteria or less stringent diagnostic criteria need to be adapted and need to be changed in our laboratory procedures. And nowadays, as we have identified ADAMTS-13 as the cause of this disease, this assay should be performed. So what is the role of ADAMTS-13 quickly? We have, I have actually a pointer. We don't see that. The von Willebrand factor is generated in this multimers. That's fine. In the multimers. And whenever there is turbulences, it can accumulate, and we have under physiological conditions accumulation of von Willebrand factor and thrombocytes. This is what we want. But on the other hand, in a normal human being, we don't want the von Willebrand factor to accumulate, and therefore we have ADAMTS-13, the von Willebrand factor cleavage enzyme, which then leads to the degradation. As soon as degradation of the von Willebrand factor and helps us prevent thrombosis. Why is ADAMTS significant? And not only on the biological way we understood that ADAMTS-13 is important, and we know about genetic analyses of Upshur-Schulman syndrome patients. But we know that patients with severe ADAMTS deficiency are more prone to relapse. We know that the diagnosis of TTP correlates with ADAMTS, with a severe ADAMTS deficiency and TTP, and therefore the rapid diagnosis of TTP with the ADAMTS is important for us. And we can exclude other diseases like the hemolytic uremic syndrome, especially in the atypical form. So here's an example. It's very clear-cut that the TTP patients has basically abolished ADAMTS-13 activity, whereas differential diagnostics like atypical HUS or streptococcal HUS, or also secondary TMAs by preeclampsia or cancer at normal ADAMTS levels, whereas TTP patients have reduced ADAMTS efficiency. There's some data from Johanna Kramer showing that this deficiency, this strong deficiency of ADAMTS-13 is prone to relapse in red, whereas my patient with higher ADAMTS efficiency in TTP is less likely to relapse. So there is a current concept of diagnosing the TTP level, which is the microangiopathic hemolytic anemia, thrombocytopenia, and then ADAMTS-13 deficiency less than 10% or 0.1 international units. There are other tests which are available, auxiliary tests for ADAMTS-13, and which change our idea of treating the patients. And so I would like to take a little excursion with you from the laboratory to the clinical, because actually our laboratory results guide the clinicians in adequately treating the patients. So there is two causes for ADAMTS-13 deficiency and therefore TTP. On the one hand, there is the lack of ADAMTS-13, so therefore the accumulation of the von Willebrand factor, or there's autoantibodies of ADAMTS-13 against ADAMTS-13 as part of an autoimmune response which inhibit the function of ADAMTS-13. And therefore we have two different treatment options. We on the one hand replace the ADAMTS-13 which is deficient, on the other hand removal of the antibodies. The advantage, our primary line of treatment, plasma exchange, does the same. So there's plasma exchange. It makes sense to reduce, give glucocorticoids or rituximab to reduce the autoantibody load. Splenectomy is still a viable option, And then there are new targets like caplacizumab, an anti-von Willebrand factor antibody, which actually interferes with the interaction of the von Willebrand factor to reduce the burden of acquired TTP, or recombinant ADAMTS whenever there's the antibody, the protein actually missing. The data are very clear-cut. Plasma exchange is superior to plasma infusion in patients. Also makes sense. There's the removal of the autoantibodies and therefore also more volume of plasma being replenished by the treatment. Steroids. The clinical data, like with all steroids giving, I'm a trained rheumatologist, so the steroids are not as clear-cut, but it makes sense, and we see a positive response with the initial treatment. Splenectomy as a final source of removing the burden of those antibodies have been proven to be effective, at least in refractory TTP cases. Rituximab, same idea, reducing an antibody to reduce the burden of autoantibodies. The data are again very clear. Thank you. The historical versus clinical trials show a superiority of treatment. Rituximab, you can follow up the patient using ADAMTS-13 activity to give a response. Let me move a little bit faster to the diagnostic part. That is very easy, and one is the most important, which I think the only thing I would like you to keep from my talk is whenever you have a TMA, draw blood before you do anything else. It is really important for adequate diagnosis to take a plasma sample prior any treatment. There are the 3 levels, the ADAMTS activity. Currently there are 2 possibilities, a chromogenic assay with a very low limit of quantification of below 1%, or a FRETS-based assay, not as sensitive. With that, you get extremely well sensitivity and specificity, as well as positive and negative predictive value for the diagnosis of TTP above 90%. There are inhibitory antibodies. We can detect them using an ELISA system, basically looking for anti-ADAMTS antibodies in patients, or for those of you who are familiar with coagulation, a Bethesda-like approach, like the factor VIII inhibitor. Again, a very clear cut, and on the left side, the mixing study for the inhibitor assay. The classic sandwich ELISA for the antigen, basically determining the antigen content, which can give additional information, especially when you have differential diagnostic between an acquired TTP or the Upshaw-Schulman syndrome, which is the inherited form of ADAMTS deficiency. But what is still the problem? What is still there? Yeah? And this is the major thing. Yes, there are assays, but still people aren't using it. You send off the samples. It takes up to several weeks to get an ADAMTS result. But the problem is that those patients are critically ill patients. They need an answer now. They need a treatment now. So typically, they are sent out samples. Only a few labs run the ELISA in-house, although it is there, and we don't discuss the costs of a plasma exchange compared to ELISA, because then the ELISA beats the plasma exchange by far. But nevertheless, it is an issue. So what we have developed in the recent years and launched in December last year is a screening assay for this purpose. Is really to meet a semi-quantitative flow-through assays with pre-incubation of plasma, detecting the antibody cleavage site-specific antibody, and in an assay time for a single patient within 30 minutes. Some of you might know these cards from other assays, like D-dimer or CRP. It's a very simple system to really quickly identify a TTP patient. And I really encourage you to do that, because the TTP patients are really critically ill and need fast treatment but only those who are really TTP patients. The correlations were extremely well compared to the gold standard ELISA. And so I would like to just, in my last 10 seconds, look into a potential workflow, which is you have the critical sick patients, draw the blood, initiate a plasma, if it's a TMA patient, a suggested TMA patient, do the ADAMTS screening test. If it's above 10%, it's very unlikely to be TTP. Continue your diagnostic, atypical HUS, secondary TMAs. If it's below 10%, it's very likely to be a TTP patient. You can initiate initial therapy, but then, very important, run a quantitative ELISA, send it off, get your result for a quantitative system, including additional auxiliary ADAM diagnostics, such as inhibitor or antigen levels, which leads you to the final diagnosis. And then therapy, which is then monitored again via the activity and sometimes the inhibitor. Thank you for joining me on this little talk. Thank you very much.
Thank you. Thank you very much, Mr. Binder.